Our next presenter for this session is Dr. Jason Carey, who serves as Medical Science Liaison at GRAIL with over a decade of oncology molecular diagnostic experience. As a Medical Science Liaison at GRAIL, Dr. Carey is a critical component of the GRAIL implementation process via physician education and post-positive follow-up. After receiving his PhD from Clark Atlantic University Center for Therapeutic Development, Dr. Carey spent 8 years at MD Anderson Center developing novel drugs for clinical trial investigation. Please join me in welcoming Dr. Carey. It's for you, boss.
Thanks. So I'm really not a fan of those backgrounds because I'd rather say, why am I here today in front of you? And the reason for that is when I started down this PhD track, I needed to know that when I wake up, I had to have a motivation or a reason for getting up in the morning that did good in the world. So that's really why I'm here talking to you today about multi-cancer early detection. And so before I get started, I actually want to highlight what Vinny, or since I'm an academic, Dr. Reynolds said in one of his presentations, and that is that early detection is like a smoke detector. And as I talk to you today about multi-cancer early detection, I want you to think about it like a smoke detector. A smoke detector allows you a chance, an opportunity to catch a fire at the earliest time point to be able to do something about it before it turns into a bigger problem. And that's what we're seeking with multi-cancer early detection, the ability to do that. I'm also going to take an opportunity to highlight one of the other previous speakers that talked about biological prevention. And what some of my colleagues talk about, we actually talk about that as precision prevention. We exist in the oncology space today in the world of precision oncology. Well, the concept of precision prevention will allow us to know who needs the appropriate screening on an individual basis. And I actually feel that's a different test than what we're talking about. That may actually fit in the realm in between early detection and the ability to prevent it altogether with the appropriate gear and understanding exposure and risk, etc. So this is a disclosure slide to simply say that this is not medical advice. This test should be ordered under the guidance of a primary care physician or a physician. So I have to highlight, GRAIL was founded in 2016. It's headquartered in Silicon Valley. And really, this was a thought, an idea into what more can we do to detect cancers and possibly at the earliest time point. And so to start off on that process, we really understand it. What are our limitations of what we're doing today? We understand that we're screening for cancers individually with single cancer screening at the time, with breast, lung, colon, and cervical cancer. And all of these guideline recommended cancers have limitations: discomfort, inconvenience, unnecessary exposure to radiation, the false positives, and the missed cancers. And so when we set out on this pathway, admittedly, we wanted to focus on the largest net of improvement based off of what we're doing with the single cancers. Right now, those screening modalities cover less than 30% of cancers diagnosed each year. And so we wanted to develop a tool, not to replace any of the current screening tools that we have, but how do we address the 71% of cancers that are diagnosed each year that we're not even screening for? And what happens by not screening for those cancers? They typically present at later stages, stage 3, stage 4, etc. So that's really the unmet need that Gallery focuses on when we launched it. But I also want to highlight, we have to understand what is the difference between early stage and late stage diagnosis. And even with the cancers, with the screening tools that we have, colorectal cancer as an example, a cancer where we have multiple screening technologies to utilize, we're still detecting approximately 58% of cancers with regional or distant metastasis. But for the cancers that we have no screening tools for or limited options, pancreas, ovarian, esophageal, etc., they're predominantly detected at later stages. And so we want to harness the ability to detect these cancers at earlier stages when we know that imparts a favorable survival, 89% when a cancer is localized versus 21% after it's metastasized. However, quite frankly, my perspective is we should not be living in a world with stage 4 cancer diagnosis. There is no need. Because if we could eradicate just stage 4 diagnoses, that only encompasses 18% of cancers diagnosed each year, but they equate to 45% of cancer-related deaths. So we can impart significant benefit to mortality, to life save, if we diagnose more cancers at any stage earlier than stage 4. Now, the title of the presentation does focus on cancer in high-risk populations, and admittedly, we focused on one high-risk population in particular, and that is the age-associated risk of cancer. And that is because anybody above the age of 50 is at a 13-fold higher incidence for cancer than anybody under the age of 50. That's based off of SARE data. But we also focus on additional risk factors such as smoking history, personal history of cancer, family history, etc. I want to repeat, this test is not meant to replace current recommended single cancer screenings. The process of Galleri is designed to detect a cancer signal, not replace single cancer screening, optimize overall cancer detection, and lastly, minimize harms. And what we consider minimizing harm is providing a positive result for somebody who does not have cancer. So what you'll see is that on our slide, when we set out on this journey to develop a test that can detect more than one cancer, there were 3 primary objectives we focus on. And that harm is emboldened at number 1. Achieve the lowest false positive rate through high specificity. Secondary, we wanted to limit overdiagnosis. And through the basis of the technology, by detecting these cancer signals in the blood, the technology in itself allows us to make sure that we're detecting clinically significant tumors. By the evidence of the clinical data, we're detecting the cancers that you want intervention on, the ones that have higher mortality rates. And then lastly, the localizing ability. It is a novel feature to do a blood draw and be able to say, there's a cancer signal and it's associated with the lung, with colon. And so right now, I'm going to highlight some of the technologies at play. But somebody spoke earlier about how the different languages that were spoken between Spanish, and they may speak French. I'm going to speak a different language compared to my previous presenters that focused on mutations, where we actually focus on DNA methylation patterns. And the reason for that is we looked at all technologies, mutations, chromosomal alterations, as well as DNA methylation patterns. And again, we were looking for a signal in the blood that we could trace back to a source with a low false positive rate and high sensitivity. And as a result, what we saw, there were limitations with other technologies. In particular, mutations allowed us to detect a cancer, but didn't achieve a low false positive rate or a cancer location. Copy number alterations, again, had similar limitations. And so based on this 15,000 person clinical trial, we saw that methylation was the only technology that checked all of the boxes. And so some of you may be familiar with the concept of methylation and epigenetics, and that in firefighters, there's this association where PFAS chemicals actually do alter our methylation. At the time that we entered this process, I assure you, we weren't focusing specifically on methylation or the fact that, or PFAS chemicals in particular, but it was just the best technology that allowed us to be able to screen cancers in the blood. And so this was a multi-step process going through 3 different phases, where in the first step, we actually compared those technologies one by one. We even attempted to combine them into one multi-omic test. And you know what we found is by combining these technologies, we actually increased that harm I was talking about, whether or not we were increasing the false positive rate. And so by combining all technologies, we actually did increase that false positive rate. And so moving forward with methylation, we combined that with a machine learning classifier algorithm that allows us to sift through all of this genetic information. We talked just how vast the human genome. Every time we run a sample, we're looking at over 1 million probes, over 100,000 CPGs in the genome. Now, we've actually extracted only the regions. So this is a targeted methylation panel, but we've extracted the regions that we associated with the cancers that we looked at in this study. So lastly, we validated in the third sub-study, the clinical validation study. And so when you think about multi-cancer early detection, or Galleri in particular, I want you to think about it as how good is this technology in addressing the limitations of the biology of cancer? And by limitations, what I am addressing is the fact that not all cancers are the same. I know we view them all with negative connotations, but there's a reason why someone with prostate cancer has a 98% 5-year survival rate, whereas someone with pancreatic cancer, even diagnosed in stage 1, has only approximately a 30% 5-year survival rate. It's because not all cancers are the same. So even when we came to look at the ability of our tests to detect multiple types of cancers, they're actually grouped into 2 cohorts. Across all 50 cancers that were detected in the study, the sensitivity is 51.5%. But when you break that down into some of the more aggressive cancers, these 12 cancers cover 2/3 of US cancer deaths each year: anus, bladder, colon, esophageal, head and neck, liver, lung, lymphoma, ovarian, pancreas, plasma cell, and stomach. The sensitivity is at 76.3%. And so these are the more aggressive cancers where we want to have intervention on, but we know that the test has a higher sensitivity for. And so we can see those sensitivities by stage: stage 1, stage 2, and stage 3. And we can see the aggressive cancers are more aggressive, have a higher sensitivity in this grouping. Now, I like to lean into what is a possible question or negative connotation. And one of the questions that I often get asked is, well, the sensitivities are relatively low in earlier stages, right? We see in stage 1, we have a 37% sensitivity even for these highly aggressive cancers, but that goes up to 70% in stage 2. Well, one of the factors that we typically don't consider with a cancer diagnosis is when did that cancer occur? And it was touched on today, is that the actual presentation or diagnosis of that cancer can actually be the downstream effect of years of cancer biology and development of that specific cancer. And so what we have is actually an opportunity by looking at these stages, how long does a cancer exist in stage 1, to where each year, if you were using this on an annual basis, you have a 37% chance of detecting in stage 1. Or if you're doing this on a continual basis, when that cancer goes from stage 1 to stage 2, where it is still highly curable, your chance of detecting in stage 2 increases to 70%. And so that's the opportunity we have with screening. Following a screening regimen is the opportunity to detect those cancers at the earliest time point. Now, I emphasized in the beginning that this test is not meant to replace current cancer screening modalities, and you can see the aggregate sensitivities in the cancers where we have screening options versus the ones where we don't. We can see that it's much lower. So this should not replace PSA screening, especially for firefighters. If firefighters are doing the Gallery test, they should be continuing the PSA screening. If they're women, mammogram screening, etc. However, everything to the right side of the screen are cancers where we're not screening for, and we're waiting for patients to present with signs and symptoms in order to be able to detect them. And when they present with these signs and symptoms, that correlates with a later stage diagnosis. Now, I want to go back to that 51.5% sensitivity overall, because that means we missed 48.5% of cancers in that clinical trial. There's no way around it. So we needed to understand what happened when we miss a cancer. And this goes back to that concept that I talked about, the biology of cancer, to where if a cancer is detectable, what does that mean versus where it's not detectable? And what you can see, based on these survival curves, the cancers that are in red, it's meant to delineate that as the chart progresses down, those are individuals that have died in our clinical study. So what this shows is that the cancers we detected are the more aggressive cancers. The cancers that we missed, independent of stage 1, stage 2, stage 3, stage 4, are actually less aggressive by nature. And so what this says is we have here a delineation of a new biological feature, or a feature that we may have known but just didn't properly understand in being able to detect cancers in the blood. And that feature is that you could theoretically have a lung cancer, both stage 2, one that's detectable by our test, one that's not detectable by our test. The one that's detectable is suggestively more aggressive by the data, imparting a lower survival or correlating with a lower survival. And so in summarizing this data, this test detected over 50 different types of cancers. Here in the top, we have the cancers where there are currently no screening options versus the ones where we also have screening options and the cancer also detected. Now, one of the key characteristics of a screening test is the positive predictive value. How good is that test at correlating a positive result to a cancer diagnosis? And in this test, it stands at 44%. Now, does that sound impressive? It should, because it's tenfold higher than all of the other screening tests. By far, the best positive predictive value than any of the USPSTF guideline recommended screening options. It has a 0.5% false positive rate, and I've already highlighted the sensitivity across stages for all cancers, as well as those aggressive cancers. I want to come back to that ability to determine what should we do next, right? And Dr. Reynolds or Vinny talked about this. It's not just about being able to say there's cancer or telling somebody there's suspicion of cancer. It's really what comes after next. And that 0.4 positive rate is to make sure we're limiting the amount of people we actually give this very detrimental information to. But this other component of being able to say where to look next, believe it or not, for most people, the pathway to suspicion of cancer to cancer diagnosis can often be a long and arduous one. It can take months, in some individuals longer than a year. And so the accuracy of our tests and being able, in terms of accurately designating where we should be looking for that cancer is approximately 89%. And so this is the test report. It's a binary report that says cancer detected or not detected. But in the case of where a cancer is detected, it also provides a certain confidence in how, in the algorithm in determining whether it's one cancer or another. But going back to that diagnostic workup component, this is the most important part. Again, this test is just a tool. The test itself does not diagnose cancer. It cannot definitively determine that there is cancer until we have follow-up diagnostic workup and a confirmatory pathological designation. And so these are the diagnostic evaluations associated with our various cancer signal of origins. We have 21 in total, and they're designed around the diagnostic workup. Some of the cancer signal of origins are grouped around specific multiple cancers. Bone and soft tissue refers to your sarcomas. Your head and neck refers to multiple head and neck cancers. However, some are correlated with just one cancer type, such as ovarian, uterine, etc. Okay, this somehow. Okay. So I want to come back to what we're used to with the acceptance of cancer screening. And quite frankly, we're looking at the evolution of the technology. And this is not meant to say that this will be the perfect screening test, but what you're actually witnessing is a change. The change in our ability to utilize technology to improve upon what we were doing, to have a better product, to detect more cancers, to save more lives. And so based off of what we're used to with the screening technologies that we have, mammograms, stool-based screening, we can see that those technologies have a high sensitivity. But in developing a test with high sensitivity, specificity is the factor that often suffers, where you can see 11% false positive rate associated with a mammogram, about a 13 to 14% false positive rate associated with Cologuard, and about 13% false positive rate associated with low-dose CT. Again. Okay. All right. So I also want to harness. I also want to highlight. Should I just say next slide next time?
Try one more time. If not, we'll do that.
Okay. I also want to highlight our clinical development program. Most of the data that I've presented thus far is from one clinical trial. As you can see, we have over 330 participants enrolled in our clinical trials. We're looking at women who are actively undergoing mammograms. We're looking at individuals at high risk for lung cancer. We're assessing the clinical implementation in our Pathfinder study. We have one of the largest screening studies of over 140,000 participants that we're partnering with the NHS in the UK. In addition, we're repeating this Pathfinder study. So all of this is designed for us to understand who should take this test, when should it be implemented, because it's not a clear-cut science. Like I said, we started off with simple criteria. What are the unmet needs? What cancers aren't being diagnosed at earlier stages based off the screening options? But there's more information to understand. Next slide. So I also want to come to our Pathfinder study. So this was a clinical implementation study. Next slide. And so this study was designed to represent how does this test work in as real-world a population as possible. And again, our goal was to detect cancers earlier. And what you can see is that MCED increased or doubled the number of cancers detected versus standard of care. Also, 50% of new cancers were diagnosed in either stage 1 or stage 2. More importantly, there were no adverse events associated with diagnostic workups, and the prediction of accuracy fell within everything we had seen from our previous study. Next slide. So here we have a summary of all 36 cancers in 35 participants. And we can see that when we talk about elevated risk cohorts, which firefighters are included, we saw that we detected more cancers than that grouping. And there were also a number that were detected in a non-elevated cohort. I have to step back and actually say what those elevated risk cohorts were. So this was a study population of 50 and above individuals. The elevated risk cohort included individuals that had been previously diagnosed with cancer, family history of cancer, smoking history, or hereditary cancer. So what we actually saw was that the test performed better in high-risk populations. 48% with non-recurrent cancers had early stage 1 or stage 2. Now, we don't have time to go through all of these, but there are a number of different stories. And remember, each one of these positives is a patient, and each one of them is a cancer diagnosis. There's this difference between clinical studies and actual implementation. When you do something in the lab, and I worked in the lab for 8 years, as Dr. Caban-Martinez mentioned, and everything works perfectly when you have the right conditions. When you try to do it in real people, that often doesn't happen. And so from the statistics, our test has a 30% sensitivity for breast cancer. But what we saw is that we detected 5 recurrent breast cancer. It was actually more than any other cancer type. And so what was apparent was that this test detected cancers in breast cancer survivors. And the interesting component to all of this is that there's actually a gap in the medical treatment for breast cancer survivors to where local imaging is recommended on a frequent basis, but there's no whole body imaging applied to those individuals. And so all of these individuals had not only recurrent, but metastatic cancer, to where Gallery was able to detect those cancers. And we're not talking about stage 3, stage 4. Some of these women were stage 1, had been in remission for 9 years, stage 2 in remission for 6 years, etc. Another example are these 2 colon cancers. In this screening population, the adherence to colon cancer screening was 92%. So why were we still detecting colon cancers and they weren't detected by other means? Well, both of these individuals were above the age of 80, no longer fitting the guidelines for colon cancer screening. And here was the opportunity where Gallery provided additional coverage for those individuals. So those are just a few of the examples. We have, there was a duodenal cancer that was detected. We also had a stage 2 pancreatic cancer that was detected, etc. Next slide, please. So I just want to highlight again, I talked about how things work great in a clinical setting, then when you take it to the real world. Well, that was the purpose of assessing both of these studies. This was a case control observational study where Gallery itself did not actually have any impact on the treatment or outcome for the patients, but it helped us to understand the false positive rate, positive predictive value, as well as a cancer signal of origin. When we actually unleashed this like a true screening test in our Pathfinder study, it matched, the statistics correlated very closely. Okay. And so now I want to come to the commercial usage. And before I go into this, I do have to highlight that we are screening this test in firefighters. But from all the data that I showed you, we did not develop this test with firefighters in mind. Not because it was intentional, it just was not a part of the initial ethos, right? What I showed you, we were looking at how do we address this vast swath of the population. Well, once firefighters came to us, we then started screening them within a real world study to really assess how this performed. And so they're a smaller cohort, but I'll highlight some of the statistics of the test overall. 50,000 tests completed, over 4,400 providing prescribers. We have about a 1% test result. 99% of the test results were negative. The test does not change the incidence of cancer, right? 68% of the cancers that were detected were in cancers without recommended screening options. You can see the number one signal was lymphoid, followed by colon, prostate, breast, and head and neck. Here's the evidence of, are we detecting cancers in a real world setting in earlier stages? Of the 108 confirmed cancers, these were the stage 1 cancers that were detected: pancreas, esophageal, gastrointestinal, uterine. Stage 2, breast, colon, liver, rectum, etc. And here are all of the cancers listed. And so I'll stop and we can take some questions. No? Oh, sorry.
For like the 130 people that were positive in your last slide, there, 108 you detected cancer.
Yeah.
What do you do about the 22 that you don't detect cancer? It's like similar for a Cologuard, where you have positive, it's a non-invasive colon cancer screening, and then they have a negative colonoscopy.
So we've actually developed a Oh, sorry. So the question is, what happens when somebody has a positive and a negative workup, basically, right? What do you do with that patient? Like, what do you do about the anxiety? And the short answer is we've developed a retest program. So we will do a positive. If there's a negative workup, you can submit to GRAIL for a free retest. So that actually has worked out really great. Sorry, and I should delineate 3 to 6 months later. And so what it actually helps us to do is figure out, is it a true positive or a false positive? Because they're actually, more than something being a true false positive, there are a few other reasons you could have a false positive. Because we tell you where to look, if we say it's lung, it might actually have been colon, so we were looking in the wrong place. Or there are sometimes we can detect a cancer before imaging, or radiologically speaking, we can validate it. And so with that retest program, we've had cancers go from positive, negative workup, to now negative. That's a true false positive. We've had a few go from positive, negative workup, to now still positive 3 to 6 months later, and then we're subsequently diagnosed. And so in that scenario, if you're part of that minority, so it's a smaller portion of that 0.5%, it's actually almost a good problem to have, because you're waiting for the cancer to pop up to where, and it's presumably still very small. Yeah. A few more questions.
It's a good thing you mentioned about negative predictive value. I think it's what he was talking about. Because I didn't see negative predictive value there. And you mentioned, actually, at the beginning, you mentioned about sensitivity, but you didn't mention specificity, but you mentioned at the end.
Yeah. So specificity is 99.5%. That correlates to 0.5% false positive rate. Negative predictive value across studies is anywhere from 98.5 to 99.4%. So.
Thank you. And also, where you mentioned about new biological features. What do you mean with that?
New biological
Yes.
features?
New biological features.
Yeah, so the new biological feature in this test is really the utilization of methylation, or the epigenetic layer, as a screening test. We've heard today really the association with mutations and cancer, et cetera, but we really haven't broached how can we interrogate the epigenetic layer, or methylation, in terms of not only detecting cancers, but in the future, how will that correlate to treatments or outcomes, et cetera, for patients. Because we're here talking about firefighters, this test, and I meant to comment on this in the sensitivity slide, is demonstrating good sensitivities in GI cancers, good sensitivity for the lung cancers, right? It does not demonstrate great sensitivity for the GU cancers, your bladder, your prostate, your kidney. And that's because what we're finding is it's a blood test and it's secreted in the urine. However, just last month, we presented at ASCO GU, the American Society of Clinical Oncology, a paper where we demonstrated the ability to look at cell-free DNA and methylation patterns in urine, right? And so our sensitivity in blood for bladder is 34%. In this new analysis at looking at cell-free DNA in urine, the sensitivity for bladder cancers was 91%. And so again, this is a version of the test. This is a version we have now, but we expect this test to evolve, to become better, and improve. Question in the back. Yep. So we don't have any evidence to say that a cancer has cleared itself. We have had some tests go from positive, negative work up to now negative. It hasn't been associated with whether the body has cleared it. That's a little bit tricky. I think that would need to be conducted in like more of a mouse model type of scenario where you know the cancer actually exists to see it go away. I don't think you can do that as easily in the real world setting. So the short answer is we don't have any data for that. But one of the unique features of looking at methylation versus mutations, whether that's somatic or germline, is that those mutations are static. They typically don't change once they occur. We do know that there are alterations in the methylation patterns. However, what we found is because we're not looking at 1 or 2 or 3 methylation regions, and there's an algorithmic approach, like I said, we're looking at over 100,000 regions. So if you want to look at it, essentially out of those 100,000 regions, 99% of them have to fit this common methylation score in order for us to make a designation of a cancer signal. And so it's kind of a pretty high bar, biologically speaking, to where we have to call it a cancer versus PSA level is high, et cetera. CA-125 levels are above, are just generally high. Next question. Yeah. So if we go back to that positive predictive value, we still have to correlate down to total positive. So if you're dealing with a population of 1,000 people with an incidence of cancer about 1%, you would expect to have 10 positives, 5 would be true positives, 5 would be false positives. And in terms of the positive predictive value of providing that information, you're dealing really with 5 out of 1,000 people that may have that information. I discussed the retest program. So that's meant to kind of put in context what that positive result is, right? We also, this test can only be ordered by providers. So this isn't a test that you should be getting direct to consumer, having to worry about the results on your own. My job is physician education. So it's up to physician to make sure they communicate appropriately what the test results mean in both a negative and a positive. And so what you're talking about is in that case of you do have a positive, the way we communicate with providers, this test is not a cancer diagnosis. It doesn't mean anything until we have the other thing to confirm it. And so it's just a suspicion at that point. To your other point about the positive predictive value being lower than other screening tests, that's not honestly something we can control. But if you're making a screening test, we've succeeded in increasing what we view as standard tenfold. So we've done everything in our power to limit your concerns as much as possible. To go beyond that, you start messing with the abilities of the test, how accurately it can send something, the false positive rate, et cetera. Thank you.